Thank you so much for the invitation to speak. I'm going to be chatting a bit today on a large team effort that had focused on evaluating undiagnosed cases of SARS-CoV-2 infection in the United States, with our first time point for a study being last summer in 2020 after the first wave. So coming from the Institute of Biomedical Imaging and Bioengineering, bioengineers have had a hand in several different areas of this pandemic response, including detection. So our institute had the RADx Tech development of rapid diagnostic platforms, including ones that are currently being used in clinics and at-home testing. Treatment, of course, mRNA delivery via lipid nanoparticles, and development of next generation vaccination platforms. And what I'm going to speak out today, which is the development of high throughput assays for the detection of CoV-2, and more specifically its footprint, talking about antibodies. So often the true toll of respiratory virus cases and deaths is often not known until the breakout of infection subsides. These undiagnosed infections can be due to cases that occur prior to the knowledge of that pathogen presence and its spread, limits of testing capacity, unequal access to healthcare, as well as asymptomatic spread, which we have seen very prevalent in the COVID-2 pandemic. This leads to the unknowns, of course, the true dynamics of viral spread, population level immunity, and potential unknown downstream morbidities. As mentioned, this is a collaborative effort from our group here within NIBIB, as well as NCAT's Frederick National Lab, a NIAID from the NIH, and then University of Pittsburgh and University of Alabama at Birmingham. Their CTSA sites led by Steve Reese and Bob Kimberly in the extramural program. So our first question when we were putting together the study was, how do we get a representative sample from across the United States with minimal in-person contact? And our solution to this was to do a combination of dried blood sampling, which we could collect via the mail. This is an adaptation on standard technology of dried blood cards, but with a volumetric blood sampling, so it could be a precise volume that's collected and a little bit more user-friendly. And then the statisticians utilized a new quota-based sampling method from a large volunteer pool, where we had 250,000 volunteers, and they were able to select down to 10,000 participants based off of census data retrieved from the US Census Bureau. We designed in-house ELISAs for this purpose, looking at the SARS-CoV-2 spike protein, as well as specifically the receptor binding domain. We evaluated several different constructs for use, and wound up settling on the McClellan or the VRC spike, produced out of NIAID here, and then the Reagan Institute from up in Boston, their RBD seemed to have higher sensitivity and specificity compared to other constructs that we had tested. Why don't we just kind of go back in and cross-confirm positives if we have RBD positivity, and ultimately it's a polyclonal response. So if you're looking at convalescent post-symptomatic individuals, where this is a cohort of individuals who all had been exposed, where 22 of them had a confirmed diagnosis, we see great seropositivity for both RBD and spike, but the hospitalized symptomatic donors, you can see underestimation of the receptor binding domain in terms of antibody prevalence, missing out on that kind of polyclonal population. So if we're looking at a panel of serologic analytes, it's a better way to evaluate seropositivity than just one or two. We also were able to show that this was longitudinally stable, which was important for us to be able to compare within different time points as we extended this across a full year of measurements. And this was translatable across platforms. So what we can do is utilize commercially available recombinant antibodies that anyone can get off the shelf. And theoretically, if an individual runs a standard curve, they could then compare directly to the data that we have. And we're happy to ship out these controls or refer to the catalog numbers to purchase these if anyone wants to compare their data. Also, we showed matrix equivalency between dried blood and serum, as well as plasma, but that is not shown here. We determined if someone was seropositive, if they were spike or RBD positive for IgG or IgM. Basically, if they were double positive, they were obviously seropositive. However, they could also be considered seropositive if they were spike IgG positive and RBD IgM positive, in case that they were early in that establishment of seroconversion. We also looked at IgA, mostly for characterizing the immune response, but we did not use it as a seropositivity designation. So as of July of 2020, which was the midpoint of our study, our first time point last year, we had 4.6% of our samples come back as positive. These individuals had never had a reported case before, so they did not know that they had been infected with CoV-2. So this is 4.8 undiagnosed infections for every diagnosed case. And as of July of last year, there were 3 million diagnosed cases, which leads to almost 17 million undiagnosed CoV-2 infections, apologies, not cases, as of July of 2020. We saw geographic variation in these undiagnosed cases, where areas that had early outbreaks had higher levels of undiagnosed seropositivity, and areas that were subject to bad outbreaks in the fall of 2020, such as the Midwest, had low levels of undiagnosed seropositivity. Basic demographics, we could see that the majority of undiagnosed infections fell on Black or African American participants, as well as more younger participants, those that lived in rural, urban areas, and Hispanic participants. We also looked at a variety of health and socioeconomic factors. I'm not going to get into this right now, but it is published at Science Translational Medicine. If anyone is interested in digging into this, some interesting things to point out is some conditions that have been associated with a worse outcome in COVID-19, such as diabetes. And if an individual had diabetes, they had a lower likelihood of having an undiagnosed seropositivity. Now, if this is due to the propensity for the disease to present stronger, and thus an individual to go and get diagnosed for the disease, versus whether or not these individuals are being more careful because they know that if they were to get it, they had higher risk factors. We can't say that for certain right now. So where exactly are we going from here, going from this initial testing and initial data? So we had our initial sero survey in the summer of 2020. And from there, we actually wound up teaming up with the National Highway Transit Safety Administration by looking at seroprevalence and PCR diagnostic prevalence of CoV-2 in trauma victims. So we know that trauma victims have a higher prevalence of, or are at higher risk for respiratory diseases in the after being admitted to the clinic. So things such as pneumonia you see more frequently, but we were wondering if that was the case on coming in, was whether or not these people had higher levels of CoV-2 coming into the clinic. And we just posted this on medRxiv. So we teamed up with 6 different trauma centers in the US, from North Carolina, Jacksonville, and Miami in Florida, University of Maryland School of Medicine, University of Iowa, and UMass Medical School out in Worcester. And what we saw was a repeat of the patterning in our national survey, but the patterns were more exaggerated. So again, we saw a higher likelihood that Black or African American participants would be seropositive. And then there was a much more striking difference between Hispanic or Latino versus not Hispanic or Latino participants. And the age distribution was also more exaggerated, wherein younger participants had a much higher likelihood of being seropositive for CoV-2. And overall, if we compare this to similar national studies done at the same time, it does appear that these participants have a higher seroprevalence in comparison to the healthy general public. We can compare this to different trauma types. Nothing was significant here, but we can see that close traumas such as assaults do have a higher trend higher for seroprevalence. But again, there was a bit of a larger error room with this in comparison to other data. Furthermore, for the roadway users, we had a complete drug toxicology data set to determine whether or not there were any correlations with drug toxicology and drug use. We saw that there was a negative correlation with depressants and THC. If an individual tested positive for THC or depressants, they had a lower likelihood of being SARS-CoV-2 seropositive. And then lorazepam had a positive correlation, and interestingly, amphetamine and methamphetamine also trended positive for a correlation with COVID-2 seropositivity. This was a large concern with the ER physicians and first responders, as often cases where an individual is positive for amphetamines, they have a bit of delirium, physical aggression, and there's often a breakdown of PPE protocols here. So if there's also a higher likelihood that this individual might have a respiratory disease, that could put those responders at risk. Off of this study, teaming up with NHTSA, what we did was we also were able to receive more samples to start looking at the biology behind some of this. And we received matched both whole blood samples as well as separate serum samples, and have started evaluating these on a large biomarker profiling kit to look at differences in systemic inflammation in trauma patients, both in the context of infectious diseases as well as trauma types, to help understand the way that these patients' immune systems look when they're coming into the ER. So this will be useful moving forward. We hope to complete this by the end of the year. We've completed our initial screen with 200 samples, but we do hope to have data on about 2,000 samples for this, and we'll make that available as soon as we finish the study. Furthermore, we received funding from the NCI Serological Sciences Network to expand our initial sero survey into a follow-up of 6 and 12 months of our cohort. This is the exact same cohort, so the same individuals that volunteered for our summer sero survey of last year would come back 6 months after that, and then another 6 months after that. Everyone, of course, has been asking about the way that this undiagnosed seropositivity or undiagnosed cases could grow after that last summer. And ultimately, if we take a rough estimate by looking at case fatality rate and assume constant case fatality and constant transmissibility, which we know are large assumptions, so this is not published anywhere, but just as an estimate, we can see that early on there was a large amount of undiagnosed cases or undiagnosed infections compared to diagnosed cases, which we expected, which then settled out throughout the pandemic, but we still know that there are undiagnosed infections out there. And if we model it out, we can assume that by the spring after those winter waves, we could have close to a third of the US population that had an undiagnosed infection. We're currently collecting the samples for the 12-month time point to test this lab, and we have already collected and are completing the 6-month measurements on this. So we'll have individuals, samples from these individuals at 3 time points over the course of the year, where we can look at evolution of their antibody responses, seropositivity, reported COVID-2 cases, and of course, vaccination. We've teamed up with other NIHers to look at seroprevalence and seroreactivity in patients that have rare diseases through the NCAT's RDCRN network and a project led by NIAID. Pediatric cases, as well as antibody cross-reactivity, and a new study that we're assisting with on primary immunodeficiencies, looking at long-term immunogenicity of different vaccine platforms with different immunodeficient patients, be it pharmacological or genetic. We've added a multitude of assays for our follow-up studies, looking at nucleocapsid as well as different variants. So if we look at nucleocapsid antibodies, and we look at RBD antibodies, we can kind of create this quadrant style analysis where we can find individuals that are RBD positive, but nucleocapsid negative, have most likely been vaccinated and are less likely to have an infection, which of course qualifier, this could be individuals that have also seroreverted on nucleocapsid antibodies after infection. And then individuals that have been infected, which can also include individuals that have been infected and vaccinated, and individuals that are early in infection that are only nucleocapsid positive, but still RBD negative. We'll also have the information of the timing and the type of vaccination, along with the symptoms after vaccination, any known COVID-2 infections since last study, and we'll have thousands of healthy volunteers from across the country that are still participating with us. So we thank them very much for their participation in the study. And we're very excited to have this data set as it comes in, and we'll release that as soon as it's analyzed as well. Then of course, think global, act local, and then act global. This is a quote from Manu Plot from Georgia Tech. And so what we did was we started in the US, but have expanded our collaborative efforts and are working with teams in both Mali and in Cambodia. In Mali, through Patrick Duffy in collaboration with the Malian Ministry of Health, they deployed these assays on site in Mali at the Ministry of Health, and they found 60% of individuals were seroreactive in Mali. Their preprint is currently live. They're continuing these studies there as well to evaluate as different variants come in and look whether or not seroreactivity necessarily means protection. And then also in Cambodia, we're working with Dr. Jessica Manning on the role of endemic bat coronaviruses on antibody cross-reactivity with CoV-2 and variant forms of CoV-2. This manuscript is in prep. We hope to have that out in the coming months. As mentioned, this is truly a teamwork effort. There were a lot of scientists that were involved in this from the NIH and beyond. So of course, with our national study in the laboratory, this was led by Drs. Heather Kalish, as well as Kaitlyn Thomas. Sally Huntsberger is our lead statistician on the project and has done a lot of effort in analyzing the data along with our statistical team. The NCAT CTSA funded sites were absolutely critical to this effort. Again, those were led by Bob Kimberly and Steve Reese at the University of Pittsburgh. And then in our trauma study, which looked specifically at trauma victims, we also were able to collaborate with physicians at a number of different trauma centers, mostly focused on the East Coast, and our interactions with the Dunlap and Associates contracting company was mainly with Dennis Thomas and Lindsey Graham, who were essential to that effort. And we are continuing those studies as well. We're actually receiving more samples in the mail today to look at those antibody responses. With that, I will give links to all of the different manuscripts that were mentioned in this seminar, specifically our seroassay protocols, as well as our national serosurvey that was recently published in Science Translational Medicine. And then our preprint on trauma patients, which just went up on medRxiv. This work was funded through the National Institutes of Health Intramural Research Program for NCATS, NIBIB, and NIAID, as well as grants to the University of Pittsburgh and the University of Alabama at Birmingham through the NCATS CTSA program and a contract from the National Cancer Institute to the Frederick National Laboratories for Cancer Research. And with that, I will take any questions that you may have.
Wonderful, thank you, Kaitlyn. So I'm going to open it up to the attendees and panelists. While we're waiting for a question here, I also wanted to mention to Dr. Schwartz that there is a question by Naval Clients in the Q&A, and you may want to address that directly in the Q&A. Thank you. So we have a question from Rodney.
Yes, thank you for a very interesting talk. I had a question about, I think I got muted. Can you hear me now?
Yes.
We hear it.
Okay, good. I had a question about whether you can differentiate the seropositivity due to a coronavirus that was pre-existing before COVID-19 compared to COVID-19.
So we did look during assay development, we did look at seroreactivity against pre-pandemic control. So samples collected from patients prior to 2019. We only found one individual that had cross-reactive antibodies. We tested that then against OC43, HKU1, MERS, SARS, and this person just was unique with that seroreactivity. But we found also, we tested all of those samples against OC43, HKU1, MERS, and then SARS-CoV-1, and we found that we have a lot of high reactivity against OC43 and some reactivity against HKU1 in the US population, with minimal against MERS and SARS-CoV-1. However, if we start to look at international populations, especially in Cambodia, we can see that shift. Actually, far more of those are positive for the HKU1 coronavirus, which makes sense geographically, but we still have some seropositivity there. So we can cross-differentiate, but the assay is quite specific for CoV-2. And we've also added in, with all of these samples, we're also testing them for this 6-month time point, the 12-month time point, and our original time point, we're testing them against an E484K mutated RBD to kind of evaluate ability of the general US population to react against mutated variants as well. So the number of samples and just number of hands, we can't do a full panel of variants, but we picked E484K as kind of an example in terms of affecting antibody binding.
So the dream is to be able to also look at Delta rising in the population, antibody to Delta rising in the population, et cetera. Is that what you'd like to do eventually?
So we would love to go back and test for those things. With the E484K mutation, we've looked at individuals that had been infected either with the D or G614 early in the pandemic, and we can definitely pick apart at a certain titer whether an individual was infected with an E484K bearing coronavirus because they have the difference in antibody binding. But I think it's going to take quite a bit of math to get there and give the confidence intervals for that, because of course there's quite a bit of uncertainty there.
Thank you.
So we have a question by Eric Green.
Hi, Kaitlyn. Great talk. I have a question. It's kind of a clarification, I guess. So if I look on the Johns Hopkins database, it says there's something like 37 million, what I believe to be diagnosed 19 cases in the US. The 16.8 million that you're talking about, that goes above and beyond that number, bringing us up to something like 55 million cases. Is that correct?
Yeah, as of last summer. So it's going to be more than that. And it's going to be
July, right?
July of 2020. So that was
okay.
Yeah.
Oh, I missed that date. Okay.
That was so
yeah. Okay, a lot more.
Yeah, so quite a bit more, but we're because we know, especially for 6 and 12 months, since it's the same cohort, we know that cohort's going to be biased for people that are invested in health sciences and things like that. So it's going to take a lot of statistical analysis and weighting to properly reflect it. I can tell you our folks are quite well vaccinated just based off what the plates look like.
Got it.
Which again, they're coming back, they're giving us more blood 6 months, 12 months. There's also some behavioral patterning that we have to take into account there. So if we were to report just the raw data, it would seem like everyone's seropositive at this point. So we're working through those analyses right now.
Got it. And just out of curiosity on that 2020 data set from you, are the people who are providing samples sort of self-reporting their health status, and are they completely asymptomatic? Do they have, what they thought was a mild cold or something like this?
Yeah, so we do have, so they are self-reporting, and we do have, so all of the demographic information, everything like that, that's all self-reported and gathered through REDCap. So we have all of that, and then for things like, have you been sick? So we also ask them that, have you been sick? Have you had a known COVID exposure? So 50-50 on the have you been sick in terms of whether or not they're seropositive. Some people did have the sniffles, and it possibly was COVID-19 that they had without knowing it. But then again, I've known a number of people that said, I swear I had it, and then got an antibody test and they were seronegative last year, back when the antibody test craze started. I can't tell you what antibody test they used because that was a whole other ordeal last summer. But yeah, so we do know, for example, if somebody was exposed to COVID, they had a higher likelihood of having an undiagnosed COVID-2 infection, which kind of makes sense. So we have that information, and we'll be following up. So all of these original individuals had never previously been diagnosed with a COVID-2 infection. So they did not ever have a reported infection. They were never diagnosed with it. However, we can assume that in the 6 months after that, some of these individuals caught COVID and they know it. So they'll be reporting that to us as well. So hopefully something else that I'm interested in is with the addition of nucleocapsid, and we have the vaccine questionnaire, we'll start to be able to pick up some of those undiagnosed post-vaccine infections as well. That may have been asymptomatic.
Perfect. Thank you.
So a lot of data on the horizon. Just it takes a bit to tread through it all.